we've transitioned to rounds. I guess I don't get active hecklers. I can only see them on screen. But just like with Rebecca, if you have questions, please put them in the chat, and then I will find a way to actually look at the chat if I can figure out a way to do that. If I don't answer your questions, maybe Rob, if you can just put your hand out, and then I'll know that there's a question, and then I'll stop and I'll ask you to ask the question.
Sure.
Okay, so this is obviously a very big topic in the last several months. A bit of controversy, and obviously we're always trying to push the edge of the envelope with the use of POCUS. So let's dive right in. So the objectives are basically, why would you use POCUS in your COVID patients? How are you going to scan your patient's lungs? What are the methods to keep your ultrasound machine clean? What to look for in your patient that has possibly COVID? And finally, what are the possible ways of integrating your POCUS findings in your assessment of your patient and your management and your disposition? So just remember a couple important caveats. 6 months ago, nobody knew what COVID was in Quebec. So there clearly aren't any large randomized prospective control trials. There are some that are starting, although the number of COVID patients right now in Quebec and in Canada has dropped significantly. But of course, with our second wave that everyone is expecting, we will probably see that come and increase a lot. As a result, we really can't rely on any randomized control trials to tell us what to do. We rely on a lot of expert opinion from those experts around the world, small observational trials. And of course, your own use of POCUS will depend on how comfortable your use of it is, your patient inflow, it's a very busy department or a very quiet department, and of course, some local testing policies that will change how you use POCUS. So why do you use POCUS instead of other traditional methods to assess your patients? Well, lung POCUS, we know for traditional pathology such as diffusions, pneumothorax, pulmonary edema, is far, far better than a chest x-ray and is comparable to a CT scan. And data extrapolated so far from what we've seen suggests that this is the same thing and is true for COVID. Just to let you know that a chest x-ray is seen to be normal in up to 60% of symptomatic patients that are COVID positive. So just imagine that you are going to send your patient that has potentially COVID, that many patients' x-rays will be read as normal after the fact. There's much less contamination risk because the POCUS is being done by the same physician that's in the room who already has their own PPE on. And at the same time, the physician can also assess the other organs that are needed in your assessment of your patient who might be hypotensive or having other symptoms. And this is really also important. There should be no equipment dangling around your neck. If you can imagine, if you're wearing a face mask and a face shield and you're putting on a stethoscope, and then after your use of stethoscope, you have to clean with your dirty hands, go underneath your face shield and try to unclip your stethoscope. I mean, you're bound to contaminate yourself. So really, you must keep your stethoscope outside the room. And as Jerry has mentioned to me, the throwaway stethoscopes that we are all given are so useless that it's another reason why you should never even use them anyway. All right, so how do you perform your exam? Well, first, you've got to prepare your machine, and it's a very clear philosophy. The machine goes in clean, and then must come out of the room clean. And some key points, again, it depends on where you work. You could consider having a dedicated POCUS machine for your COVID patients. That way you don't have to risk contaminating multiple machines. And then the idea of having either a cart-based or a handheld system, again, has benefits and disadvantages to both. Regardless of which one you're going to do, you're going to strip down your machine. You're going to remove any accessory probes you're not going to use. You're going to remove the towel rack, anything like that. You're going to go in with one probe if you need. You're going to place your probe cover over your machine and your probe. You can buy from any store these extra large clear plastic bags to go over the machine. There are also sterile probe covers that you can buy, but these are expensive, the ones that we use for central lines. Obviously, if you're going to do a sterile procedure such as a central line, you should use them. But to protect your probe, then there are ways that you can buy large quantities of these rolls that you can then cut to size and then use them for your probes. And in terms of gel, you should try to use single-use gel. You shouldn't go in with an entire bottle because you're technically contaminating that bottle. So what I do and what many people do is you come into your shift and you prepare these 10 cc syringes of gel. And then the bottom picture on the right is what my bucket is. It has my probe cover, my probe, my 2 things of gel, and I'm ready to go into the room to scan my patient. And that way I don't need to bring and contaminate gel bottles. In terms of protocols, I think every hospital should have an institutional protocol for preparing your machine, as well as I'm sure many of you guys have protocols for preparing your cells for PPE. If you go to the POCUS website, they've actually published guidelines in 12 languages, which is fantastic. So it's used all around the world, where you can actually print out a PDF or a JPEG of the protocols, whether it's going to be for a cart-based system or a handheld system. And what we've done is we've actually taped these to our machines to remind people of sort of the procedure of using PPE for your machine. In terms of which probe to use, but basically any probe is fine as long as you have them on a lung setting, a preset, so that you can decrease the filters on the machine and you can really focus on the artifacts that you're looking for on your lung. So remember that COVID-19 will cause a multilobar pneumonia. If you look at this CT scan, you're going to see that you're going to start to see images of lesions everywhere on this patient's lungs. It is found predominantly posteriorly and in the inferior portion of the lungs. And as a result, you have to include more lung zones than what you would traditionally scan for if you were worried about, for example, pulmonary edema or a pneumothorax or a pleural effusion. You really have to scan many more lung zones. So the traditional way is to do a 12-zone assessment, so 6 zones per lung. So that's going to be 2 anterior, 2 lateral, and then 2 posterior. And you really do have to make sure that you look at the posterior lung zones. And what you're going to basically do is, using a lot of gel, you're going to use like a Zamboni going through the anterior lung zones, looking at both the areas, going up the lateral lung zones, and then looking at the posterior lung zones to see for any evidence of what we would look for pneumonitis. It may seem daunting because you have 12 zones to scan, but with practice, this entire exam can be performed in 1 or 2 minutes and provides a tremendous amount of information as to what's going on with your lung. So what are you looking for? You basically have to focus your eyes on the pleura and the pleural line. So just to give you a reminder of what normal lung will look like. So these are your ribs and the rib shadows that you see, and about 1 centimeter below the rib shadows will be your pleural line and that lung sliding that's going back and forth, and distal to that will be your grayed out lung, which is obviously dispersed from the sound waves hitting the air. In between that, you can often see these horizontal A lines, which is just a reverberating artifact from the pleura. And this is something that sort of helps you determine what is going to be normal lung tissue below that sliding lung and what might be pathology. So for example, here's another example of a pleura, which is nice and smooth and it's sort of shimmering back and forth. And then A lines, which are these horizontal reverberating artifacts, which in this context just tells you basically that there's normal lung. So what are you going to see in a patient with COVID? Well, early on in the disease, you're going to be seeing focal patchy B lines. So you see these B lines, which are very, very bright white echogenic lines that start from the pleura and they go all the way down to the bottom of the screen. And what's important is that it's focal, which means that there are skip lesions at one space above or one space below. You may actually see completely normal lung with those horizontal A lines. And that tells you that what you're seeing is really, really a focal lesion. In this early stages of the disease, the chest x-ray will very often be normal and you're not going to see these lesions on the chest x-ray. As mentioned, you see here these A lines right there, and as you scan to the next interspace, or if the patient takes a big breath, you'll see these skip lesions of normal lung with abnormal lung right next to it. Here's a patient again, sometimes it's very, very discreet here that there's these bright lines of white B-lines, and then beside it, not that impressive. And this is an elderly woman who unfortunately passed away from COVID. As the disease gets worse and worse, these B-lines will start to coalesce and they will become much wider, and what's called the waterfall sign, where you see basically one big fan of bright white B-lines that come from the pleura all the way down to the bottom of the screen. And you'll see that this is becoming more a significant disease in the patient's lungs. What you should also focus on, and this is how you differentiate from other B-line patterns, is that the pleura will become a lot thicker, appear thicker, and will be not as smooth as normal. It'll become irregularly shaped, what some people in the literature talk lumpy, bumpy pleura. And within that pleura, you'll see these little black areas of subpleural hypoechoic consolidation. And so that's sort of an indication there's this focal pneumonitis going on at the level of the pleura. So this is sort of the next step that you want to look for when you're seeing those B-lines. Focus on the pleura to see if pleura is irregular, thick, and some subpleural consolidation. Here's another example of B-lines right here. And if you'll just look on this area, you can see that the B-line becomes a little bit raggedy here, and there's this subpleural consolidation right at this point, which is not normal in this patient who ended up passing away from COVID. Here's another example of normal lung. Here's some B-lines and this sort of raggedy, dirty pleural line with a subpleural consolidation, which is quite evident in this patient. Finally, as patients become more and more sick, you'll just see frank consolidation with air bronchograms. This is a patient who has a clear pneumonia down in the base of this patient, in the right base. And that's sort of the final level of severity in these patients. So just a reminder, B-lines and pleural findings can be distributed anywhere in any type of patterns. So it's really a patchy focal area. So you really have to scan all throughout the patient's lungs and not just focus on one area. Most of the pathology is found posteriorly and inferiorly. So you really have to try to get these patients to sit up so you can scan the patient's back and down near the bottom of the lungs. And while they're sensitive, these are not specific findings. Any type of pneumonitis can cause these focal patchy B-lines, but clearly today, without a clear other history, if these patients come in short of breath, and this is what you see on your lung ultrasound, it's almost certainly going to be COVID in today's day and age. And as I mentioned, you really have to focus on the pleura. Because if you see these diffuse B-lines everywhere on your lung field, there are no skip lesions whatsoever. Your pleura is nice and smooth. It's not raggedy. It's not lumpy and bumpy. And you don't have any subpleural consolidations, then this is almost certainly going to be pulmonary edema. Now, we're seeing many, many more patients that are not coming in short of breath that have this pattern. And so all of our CHF patients that we used to see before COVID that seemed to have disappeared when COVID came are now coming back. And so this is how you really want to differentiate going down the COVID route versus the CHF route. And also look at the basis for pleural effusions. Pleural effusions such as here are very, very rare in COVID. And so this is another indication that if someone coming in short of breath and they see a large pleural effusion, this is, again, unlikely to be COVID. And the history should suggest that this is more likely to be maybe it's a transudative or exudative pleural effusion that's causing this short of breath and not necessarily COVID infection. So trust your POCUS. I know a lot of people are a little bit reticent in assessing the patient's lungs to looking for artifacts. This is a patient that I saw right away, a 59-year-old man, sore throat, fever, maybe a little bit of hemoptysis, and you can clearly see that there's some normal lung and this bright white waterfall sign of a patient that I was concerned about COVID, and he didn't look well. His chest x-ray, gotta tell you, it didn't look that impressive. But because of his symptoms, I sent him for a CT scan, and this guy had these waterfall sign in one area of the lung only. And sure enough, on the CT scan, you can clearly see that it's got this whited out area of consolidation and pneumonitis, which you don't necessarily pick up on a chest x-ray. And this you will pick up on your lung ultrasound. So trust what you see on your POCUS. So what's the utility of POCUS? And basically, how do you finally integrate these findings in your decision making? You can sort of break it down when you initially assess your patient and you make your diagnosis. Does it help? Can it quantify your severity of disease, and how does it help you follow the progression of the disease? And does it also help in making any decisions on how you would manage these sicker patients? Remember that any imaging, whether it's POCUS, chest X-ray, or CT, will never diagnose COVID. COVID is tested, obviously, with your PCR test, but it can increase or decrease your likelihood of your disease. It can define the extent of your disease, and also can help you suggest alternate diagnoses, such as, for example, CHF. So with that in mind, the way that I sort of see myself seeing a patient nowadays coming in with a shortness of breath or with fever, you know, I bring the machine in, I bring my ultrasound in, and I basically go through a systematic approach. If I see no B lines whatsoever, so what we call an A-line pattern, sure, this person still could be positive for COVID. Depending on, again, where you work, you may discharge this patient home, plus or minus test the patient for COVID at your hospital, or send them to an outpatient testing center. Could this patient have an alternate diagnosis? Could he have a PE or a COPD exacerbation based on the fact that your lung ultrasound is completely normal? But what's really important is I do not send these patients to chest X-ray. It's a worse test, and you're increasing your contamination risk in these patients. So there's no need to send these patients for a chest X-ray for this. The next is, if you're starting to see some focal patchy B lines, maybe this is early in the disease, this patient has some lumpy, bumpy pleura, maybe some pleural consolidation, this patient almost will likely be COVID positive. Again, you may discharge this patient home depending on your O2 stat, your oxygen needs, requirements, patient's comorbidities. And this patient might need to be admitted to the COVID ward. You know, you do your COVID test, your chest X-ray. I put in brackets because that X-ray for me is not very useful. For the internal medicine physician, maybe they will want to have a chest X-ray to follow. But I've already made the likely diagnosis based on what I see on my POCUS, and of course, blood work and treatment. If you're starting to see much more diffuse, patchy, coalescing B lines or consolidation on your lung ultrasound, again, your COVID-19 is almost certainly likely. These patients are going to be likely much sicker and may need to be admitted to the COVID ward. This is where you might want to have ICU involved, depending on their hypoxia. But again, you're sort of getting an idea of how bad this disease could be. Then finally, in the same category, if this patient come in with shortness of breath and you see diffuse B lines, there's maybe a pleural effusion, the pleura is nice and thin, COVID-19 is very unlikely in these patients. And then you want to manage for your alternate diagnosis. You may need to be on a nitrate or on Lasix or on BiPAP or what have you to treat your diagnosis of likely pulmonary edema in this patient. In terms of disease quantification, there is some evidence that suggests that if you do serial lung ultrasounds, you can follow the progression of the disease and the resolution of the disease. So for those who work in the ICU or an internal medicine floor, you don't need to repeat chest X-ray after chest X-ray or CT scan after CT scan. Just do lung ultrasounds, and this may provide you with an indication of the severity of the disease. If you see down at the bottom right, this Dr. Yale Tung Chen. He is a Spanish physician who contracted COVID, and he actually scanned his lungs every single day during his hospitalization and while he was at home, and he tweeted about it, and he basically showed how his lungs were progressing as he was becoming sicker, and then how he finally, how he got improved after the resolution of his symptoms. In terms of how to manage, again, this is maybe more of a issue related to the ICU. Depending on your pattern of B lines, you may want to increase your PEEP or your VIT settings in your patients. And if you have a lot of your findings primarily posteriorly, this suggests that these patients may actually respond well to pronation. Again, these are not randomized controlled trials. This is sort of more of experience from the experience in Italy for all of the intensivists and saw what they were seeing with their huge numbers of COVID patients. But if you are in an area where you can do serial POCUS over a span of several days, then maybe serial POCUS can help you with that as well. All right, to quickly summarize, obviously for me, I'm preaching to the converted to some, but you really do have to think of the ultrasound as your initial safe tool to rapidly and effectively assess your patients who come in short of breath and you're worried about COVID. It provides valuable data point in your decision making, and for sure it minimizes any contamination risk to your fellow healthcare workers, to the machines if you want to have send these patients for chest x-ray. As here, it's getting a chest x-ray and not doing a lung ultrasound will expose personnel to COVID and waste PPE in order to perform a less sensitive test. And remember that having a system in place, such as your ultrasound system, it needs to go in clean and come out clean. So have a proper use or protocol for your machines to stay clean. And please leave your stethoscopes outside your room. You don't need to use them anymore. I mean, I barely use them in the non-COVID era. When you can look at patients' lungs and look at patients' hearts, there's not much that a stethoscope will help. More so in the COVID era, where you are basically doing a very insensitive and non-specific study with your stethoscope, and you're increasing the likelihood of contamination. And I think that's about it. Yeah, just a couple more. All right, that's it. I see that there are some questions or chats. Let me see if there are any questions here.
Yeah, there's two specific questions. The first was, if you have those findings on POCUS, would you still send them for a chest x-ray? And then the second one was, if you're trying to minimize the number of probes you're bringing in the room, which one are you choosing, or are you bringing in a couple?
Okay, so good questions. So the first question is whether I'm doing the chest x-ray. It really depends on where my patient is going. If this patient looks well and I'm going to be discharging this patient, doesn't require oxygen, I'm not getting a chest x-ray. I tell them that you most likely have COVID. We do have a system in place where these patients will be sent for a COVID test, but I will not add increasing contact, especially if I see patchy B-lines, then I'm almost certainly going to be contaminating my chest x-ray technicians, machines, and rooms. So I want to minimize this patient's transport. And if I'm sending this patient home anyway, then absolutely not, I'm not adding a chest x-ray. If these patients are sicker, and they're going to be admitted, as mentioned, a lot of the internal medicine physicians will probably want a chest x-ray. That's because it's part of their standard diagnostic tools. So probably I will order it, but these are patients that are usually on the sicker route, and I know that they're going to be admitted. The other question was about the probes. I would probably use, it depends on how sick they are. If I think that they're very sick and I'm going to need to scan their heart as well, then I would probably just use the cardiac probe, because I think it's good enough to see both the lung as well as the heart. Otherwise, a curvilinear might be good enough. A linear probe is a little bit challenging because it doesn't look deep enough. And you want to really see if those B lines start to go deep into the lung fields. And then you also want to look at the bases of the lungs. So the curvilinear would be the way to go. And of course, for those that answer that question may not have merit. So for those obviously that have a handheld probe that have multiple probe settings, then the one probe basically is like Lord of the Rings, one probe to rule them all. Any other question? If you have a butterfly, you have a spectrum of probe. That's right. So that's what Jerry just said. Any other questions? If you find this on POCUS, do we need it? Yeah, that's it.
I think that's it. Thanks so much, Joel. That was excellent.
My pleasure.